Hey all, Dr. Maynard here. Today we're going to talk about the changes that we made from 2024 to 2026 protocols. We do this every 2 years, and we make sure that we're staying up to date on the most current evidence in EMS and following evidence-based medicine. And so to help you with that, I've brought a friend along with me, Dr. Bertrand, who's also an EMS medical director. And so we're going to be going through all of the protocols kind of from the top to the bottom. So you should have with you a PDF that is titled 2024 to 2026 Protocol Revision Guide. I'm going to go ahead and share that with you guys now. And we'll go ahead and take a look at this together and kind of work our way from the top to the bottom. So a little bit about the way this was arranged. Basically, if it's a section, it's italicized. If it's a protocol, it's bolded. There's also a slide deck we'll do at the very end, which will go through some of the visual changes where we can see these protocols side by side. And then in blue, we talk about the change in the rationale. So starting with the high-level organizational changes, we took a number of policies out. So these would include things like the consent, refusal, controlled substance, MCI, healthcare professional at the scene, infectious disease, transfer, and run review. And so this is completely removed from the protocol and now placed in a separate document called the creatively named policy document. So why do we do this? Well, basically we wanted to reduce the bulk of the protocols because we found that a lot of these things could be referred to later and you don't really need it for in the moment while you're using the protocols. One thing that did remain is an interfacility transfer. These would be emergency transfers where a hospital would call us as 911 professionals to the hospital in order to do transfer. And for whatever reason, maybe it's bad weather or whatever the case may be, that they want to go hospital to hospital using 911. All right, moving on here. So the patient assessment section was previously section number 2, and we actually removed it completely. And so all the subsequent sections were then shifted up. And so just keep that in mind if you're one of those types that likes to remember page numbers and the protocols. All the page numbers are going to be changed in 2026, and it's going to be a little bit, well, very different from the previous. So some of the things that we did keep in the general information section was the blood pressure reference. We know we have a lot of different cutoffs for blood pressures in our protocol, and so we wanted to make sure that we left that in. So you can find that now in the general information section. Also capnography, how to interpret waveforms and whatnot, that's also in the general information. And vital signs, how often you need to check them, or critical versus non-critical, that's all still in general information. The 12 lead indications were moved from that section in the patient assessment to the skills section. And so why do we do this? Well, basically, we found that a lot of times these were things that we already knew how to do in terms of assessing a patient, and it was a little bit redundant to add to the bulk of the protocol. So that's why we removed it. So the adult medical section, of course, is now become number 2. It's previously number 3. And it shifted up. We also have a new tachycardia algorithm design, which we'll show you in the slide deck later. The pediatrics, we got rid of the pediatric dosing chart, and the reason why is because in hand-heavy, our Braslo is what most people are using, and so we decided to just go ahead and eliminate it because people were not using that dosing chart. Also, the tachycardia protocol got a refresh and looks similar to the adult. And in fact, I'll mention this now that while you're looking at the adult versus the pediatric, a lot of the changes that we made in adult, we mirror or reflect the same in the pediatric version of that protocol. In the trauma section, now it's number 4, we put drowning into the adult medical because it's more of a, it's not necessarily a trauma, of course, unless there's an injury, but drowning, pure asphyxiation probably should be thought of as a medical cause of cardiac arrest or some type of injury. We also have a new design for the trauma arrest flowchart, which is looking a little better and clearer for you guys to see. And then I'm going to hand this next section over to Dr. Bertrand.
So the skills section now moved up to section 5. And just to help reduce the bulk of the protocols again, we took all of these protocols that you see listed, a total of 17 of them, out of the actual skills section. not because we don't think they're important, but we just think that these are things that you um, learned back in EMT or paramedic school and still retain the ability to perform without us having to exactly spell it out and take up that much space within the protocols. We also have revised the RSI and RSA skill. RSA is now its own skill and protocol, and we have details added for the indications for that. So you're going to be using this protocol if you have exhausted your DSI and you're still not at your SpO2 goal of 94% or better for intubation, then we suggest you progress to the RSA skill. I'll say that if you still are unable to get the patient's SpO2 above 94% using RSA, you'll need to use your clinical judgment as to whether to attempt intubation at that point or transport to the nearest emergency department with the pulse ox remaining where it's at below 94%.
Yeah, and Dr.
On
Bertrand, I'll jump
the
in here too because I found that
yeah,
when I asked around, a lot of the paramedics I talked to weren't even aware that there was an RSA protocol. So we preach a lot in Best EMS to resuscitate before you intubate, and that means two things. Number one, you get the pulse ox over 94%. Number two, you get the blood pressure above 90 millimeters of mercury. And so sometimes you can't achieve that greater than 94% pulse ox. And so what do? You've kind of maximized, you got your nasal cannula, you got your non-rebular mask, or you're bagging the patient, or you got them on CPAP. You've given, maybe nebulizers and Solu-Medrol. You're going way down the respiratory distress protocol, and you still can't get that oxygen saturation above 94%. So that's where RSA comes in. And so instead of placing the ET tube, you would place a supraglottic device, your iGel or whatever you have as a supraglottic. And then once you get the sat up, now you place the ET tube. So just a little bit of clarification for those who are not as familiar with the RSA protocol.
and the medication section now moved up to section 6, and we added 3 new medications. Cefepime, which many of you were already using in your antibiotic protocol. It was an addendum protocol or supplemental protocol previously, so we just placed it into the main bulk of the protocols because several agencies now use it, and we recommend most agencies try to carry it. We also added metoprolol as an alternative to Diltiazem. During last year, there became some problems with supplies of Diltiazem and how the logistical issues with how long the new supply was going to last. So metoprolol is a non-refrigerated alternative to that. And we also realized we didn't have a second. The only beta blocker we had previously was labetalol, which really doesn't work that great on heart rate. So metoprolol is a better choice if you're treating someone with, say, SVT. Vasopressin was a second-line pressor that was added. We added this mainly because, as Dr. Maynard said, we really focus on resuscitation before transportation, so stabilizing at the scene. Some of our agencies were running into patients that were maxed out on Levophed and epinephrine, and so they asked if we could add vasopressin as a third agent to utilize in those cases.
Very good. And so now we're going to go into the general information section and the adult medical section and talk about the changes. And by the way, we didn't mention it up front, but the old page numbers are listed here along with the new page numbers. And so if you ever wanted to look by page number, they're stated there. There was something we had to add to this new version of the protocol because dishes was requiring some clarification. So if you see this kind of strange wording, this or if capable wording, it basically means that if you don't have the equipment or the medication, of course, you can't use those. And if you're not trained on a procedure, of course, you shouldn't do that procedure. And so you'll see in between medications, for example, the nausea and vomiting protocol, it'll say give Zofran, or if capable, Raglan, or if capable, droperidol. And so the logic here is that if you did not carry Raglan, of course, you could not give that medication. And so just to make sure that everybody's clear about what this word and this phrase means, but it was required by dishes in order to kind of make sure that everybody was on the same page and communicating. We also wanted to just remind that if your agency does finger thoracostomy, pericardocentesis, or escherotomy, this is something that we'd like you to go to cadaver lab to be trained on. And then also the agency should keep track of who's been checked off and whatnot. If you're going to try to become checked off for field amputation, that's really something that you're going to have to do at cadaver lab. It's really hard to simulate that otherwise. Moving on to the DNR protocol, we removed the DNR necklace and bracelets because they're really not an official DNR and it doesn't really count. So we just kind of took it out to make it clear. Moving on to immobilization indications, if anybody's over 65, this is an independent risk factor for C-spine injuries. And so we made this a mandatory immobilization criteria. And that's in accordance with the Canadian C-spine rule, which is pretty much what every ER is using. The also under immobilization, the question then becomes, well, what if a patient is in a C-collar and it's causing them pain and they're thrashing around, they're becoming more agitated, and we think it's actually doing more harm than good? Well, we wrote a protocol specifically for that. So there is a part in the immobilization protocol that says if they're causing harm to themselves, then just go ahead and take off that C-collar because it's probably doing more harm than good at that point. Also, altered mental status. Here's the classic case. You come across a patient, maybe they have dementia. We don't know if they're newly altered. Is this worse than their baseline? Or if their injury caused them to be altered. And so if anybody's altered, we're going to err to the side of caution and just go ahead and treat them accordingly. And if that means put a C-collar on, that's probably a good practice because we don't know if they're altered from the injury or if they're always altered. And so we're going to err to the side of caution. So, all right, Dr. Bertrand, you're up.
In sections 29 to 30 on restraint guidelines, we changed a couple of wording issues. We changed violent to the agitated patient. We had to remove the chemical restraint guidelines in the last legislative session. There were some laws passed that gave specific instructions on how chemical restraint, quote unquote, was supposed to be used. So we still have the indications there under the psychiatric or agitated patient. We just removed the phrase chemical restraint. We also added pulse oximetry to monitoring along with capnography and cardiac monitoring on those patients that you are utilizing restraints. Several changes on scope of practice. One is the chemical restraint skill was removed from scope of practice from the paramedic list because of the above changes that I just mentioned. We changed iGel wording to generic supraglottic device because we realized that not all of our agencies carry the exact brand iGel for supraglottic devices. We added several items, in fact, to the EMT scope. Ophthalmic drop administration, which would be Alkane within our protocols. We also added they can assist with the patient's own intranasal epinephrine, and also added PO and ODT Zofran as an EMT skill. We added to the advanced EMT scope IV fluids, IO lidocaine for IO placement for local anesthesia, and we limited the ET intubation to cardiac arrest patients only. Now moving into more of the medical protocols, on the adult allergic reaction section, we increased the albuterol attribute range from 2.5 to 2.5 to 7.5. So you can give 1 to 3 dual-nibs. And we did this so that because sometimes those severe asthmatics or severe COPDers do require maybe a continuous nebulizer instead of just giving one every 5 or 10 minutes. We also, along with national standards, increased our IM dosing of epinephrine from 0.3 milligrams to 0.5 milligrams, and also expanded our anaphylaxis in that we used to previously state that you had to have airway or upper airway involvement to meet the definition of anaphylaxis. But now, again, going along with national standards, it's felt that if you have any two body systems being affected, that you're basically in anaphylaxis at that point and qualify for epinephrine. There's a much bigger push nationally from national organizations to expand our utilization of epinephrine in severe adult allergic reactions. And we also changed the nebulizer from just racemic epi to an epi dose that you can mix with 1 to 1,000 epinephrine. So 5 vials in 2 to 3 milliliters of normal saline. And we did this mainly to give you an option for epinephrine nebulizing because racemic epi is really expensive to purchase and you really won't utilize it that often. It's a great drug to utilize in those pediatric patients that you may get called on in the middle of the night that are displaying stridor from croup. This is going to be your go-to drug, along with, we'll cover it later, oral decadron. And then on the anxiety hyperventilation withdrawal section, we added droperidol as an R if capable option because this medication does really help with anxiety. It can be fairly sedating though. So we caution that if you're going to use it in anyone over the age of 65, please start with the 1.25 dose and not the full 2.5 milligram dose. We have gotten some concerns from hospitals that we transport to that sometimes we're bringing these patients in and they're too sedate for any kind of evaluation for the next 20 to 30 minutes after they're there after receiving 2.5 of droperidol.
Yep, I agreed. And just to double click back on to the adult allergic reaction, we're going to do a screenshot of that during the slide deck presentation, and it'll talk about exactly what two criteria need to be met. And then also, one other thing, I just wanted to mention that it's going to seem like you're putting a lot of medication into that nebulizer. 5 vials of 1 to 1,000 epi seems like maybe that's too much, but I always like to remember that I'm not giving all of that medication at once. They're going to breathe in and take a small fraction of that and then take it again. And so they're not getting it all at one time. And so it's going to seem like a lot of medication, but it's just a way to allow to give a long duration. And of course, if the patient improves, you don't have to give the full amount. All right, moving on to adult cardiac arrest. Smoke inhalation was added to conditions to treat medical arrest. In fact, most times somebody's in a fire, if they go into cardiac arrest, it's not because of a burn, it's because of smoke inhalation. And so we thought we would put that in. All right, now for a big rule, the new 10-minute rule, as we call it. This is the idea to stabilize before you mobilize, which is another thing that we say a lot in Best EMS. So if you are riding in the ambulance and you're the only one in the back and suddenly the patient goes into cardiac arrest, we know that from the literature that every 1 minute that goes by, the patient is going to lose its chance of survival by about 10%. So we basically have a 10-minute window of opportunity to intervene. And so if you're in the back, do you want to be working by yourself or do you want to be working with a partner that can help you be more efficient? So the idea here is that if you have to pull over because the patient goes into cardiac arrest, let's get all hands on deck. Stop the vehicle, driver gets out, goes into the back to help out. Or you call the engine over or whoever else is able to help in order to help that patient. Or if you're on scene and the patient goes into cardiac arrest, it's not a load and go situation. The patient's best chance of survival is going to be if you stay and play and you resuscitate for that next 10 minutes and then use your judgment beyond that. We also added color Doppler pulse. So if during cardiac arrest, you wanted to put color Doppler on the patient's femoral artery or carotid artery, you might be able to see if your CPR compressions are adequate. And also, if you get ROSC, it's a good way to tell if there's adequate pulse. NG or OG tubes are an option, not required, but an option, especially helpful if there's any gastric distension from overbagging with a BVM. And then finally, hypoglycemia has been removed from our protocol. And why? Because, well, this was actually removed back in 2010. So we were finally removing it. It's unlikely that that's going to help if the patient was in cardiac arrest due to hypoglycemia. It doesn't mean you can't try to give dextrose during cardiac arrest. It certainly would not hurt, but it's probably not going to help. All right, moving on to push dose pressors. We'll do a screenshot of this in the slide deck. But basically, instead of just 1 ml of push dose epi, you can now give up to 2 and every 1 to 3 minutes. And so you usually get a pretty fast response from this. So if you think the patient needs 2 mLs, go ahead and give 2 mLs. Same thing for Levophed, now up to 2 mLs. Drowning basically got moved from trauma to the adult medical section just because of the reasons we talked about earlier. And also this term secondary drowning is no longer used in the medical literature. We're kind of moving away from that, this dry or land drowning. We're not using that anymore. Also, we had this very complicated drowning flow chart that we removed. I'm not sure how many people were using that, but it was very complicated. and very small print. So we decided to take that out because I don't think many people were using it. The adult hyperthermia, patients that are too hot, we now have a cooling target. So now we have a goal of less than 101 degrees Fahrenheit, and then we stop the cooling. Now, if we continue to cool that patient, they may overshoot and actually get so cold that they start shivering, and then we're now, developing more heat from muscle contraction. And so we want to make sure that we don't overshoot. If we are submerging the patient, we have a new submersion protocol for hyperthermia. We want to make sure that we remove them from the water before we hit 101. And then also, you can put cold compresses on the forehead, the neck, the axilla, the extremity, the torso as needed while you're en route.
And I'll add to the hyperthermia protocol that the new cooling protocol will call for us to again resuscitate at the scene by cooling these people at the scene, because that has been proven over and over to be giving them their best chance of survival. And we, unfortunately, in the ER really don't have a good way to cool these people within a immersion platform. So this is going to be better performed at the scene. So that supplemental protocol has already been sent out, and you should review it. Coupling to hyperthermia, on the adult hypothermia protocol, we moved that the patient must be warm to 90 degrees before being declared dead. Previously, I believe it was at 86 degrees. And it's supported by the literature that defibrillation and ACLS meds are really ineffective at cold temperatures. Remember, they're not dead until they're warm and dead. And now this, unfortunately, will probably not be something that you will be able to completely accomplish in the field. It takes a while to get someone really warmed up for resuscitation. So I would start the process and then start transporting them when you're able to.
Yeah, I think the learning point there is that when you have somebody who's really hot, hyperthermic, they actually cool off pretty fast when we submerge them, especially, or even if we're just doing ice packs. When you have somebody that's really cold, it actually takes a really long time for them to warm up. And so if you're thinking on scene, you got somebody with a core temp of, 84 degrees, you're going to warm them to 90. That's actually going to take several hours to get them warmed up to 90 degrees. So trying to warm them and then do termination resuscitation on scene is probably not the direction you want to go. You probably want to try to just transport that patient.
On the migraine and nausea vomiting, we moved droperidol forward in our migraine treatment. Most agencies carry droperidol, and for most of us practicing in the hospital setting, this is one of our very first go-to drugs for treating migraines. We also, on the nausea vomiting section, we moved Zofran first and droperidol and Reglan as an R/if capable medications, because Zofran should still be your first line, and droperidol and Reglan as your second line. And we increased the Reglan dose to 10 milligrams. It was previously 5 milligrams. But be aware, again, that droperidol and Reglan do have some sedating effects. So in those geriatric patients, you can still, we recommend 1.25 on droperidol and maybe 5 milligrams on Reglan. Also, remember, if you get anyone who gets really the feeling that their legs just can't stay still after receiving those drugs, that's called an akathetic reaction and occurs in about 6 to 10% of patients. A great remedy for that is going to be Benadryl, 25 milligrams IV in an adult. Okay. Moving on to the OB section, we changed our magnesium sulfate IV and IO loading dose from 6 milligrams to 6 grams to 4 grams. We felt comfortable at 6 grams. We were getting some pushback from some hospitals that they felt like it was too much, even though we consulted with our OB specialists, and the ones we consulted, feel comfortable at 6 grams. We just moved it back to 4 grams for now. On the delivering complications, we realized we didn't have two things. One, we didn't have delayed clamping of the cord. This is actually recommended by most organizations now. It allows for increased infant blood volume by 20 to 30%. We want them to get as much of that maternal blood as possible. And this will therefore have better hemodynamic outcomes, hopefully, for them. We also realized we did not have a nuchal cord treatment section, so that's been added for you to review as well. On the adult overdose and poisoning, and this will also coincide with pediatric, we changed organophosphate poisoning to, instead of 2 to 3 milligrams of atropine every 5 minutes, to 3 milligrams every 20 minutes until secretions diminished. And this was made not because this is the recommended dosing now, but because if we would have you to require it every 5 minutes for some of our rural organizations, they would have to carry a very large volume of atropine that they would probably never utilize. So that was the main reason it was changed. Um, you could still give it every 5 minutes if you need to. Okay, that can be a medical control call if you're close to the hospital, but you're going to probably run out of your supply anyway, and you'll probably run the hospital out of their supply if you have a true organophosphate poisoning. And again, we talked about the Benadryl treatment for the dystonic or acesthetic reaction you can receive with droperidol, Reglan, Finnegan, any of those medications.
Very good. All right. And then moving on to the adult respiratory distress protocol, we took out the fluid bolus from the asthma and COPD section. There's probably some patients that would benefit from a fluid bolus. You lose a lot of just insensible losses when you're breathing a lot, water vapor that you're breathing out. But what we found is that in the literature, it really didn't make much difference. And so probably something that can wait until they arrive to the ER if they thought that that was necessary. The nice thing about this here is in adult respiratory distress, these medications all are exactly the same for allergic reaction, which we already covered. And so your albuterol dose is increased along with your Atrovent. Your IM epi is increased, and your epi nebulized is also increased, and it's exactly the same as the allergic reaction protocol. So easier to remember and uniform across the board. All right, so adult sepsis and antibiotics. One of the things we wanted to emphasize is that if you have a septic patient and we can't get an IV, although IV is probably preferred, if they're unstable, just go straight for the IO. So that's kind of like explicitly labeled there now. Antibiotics were previously a supplemental protocol, and now it's basically put into the sepsis and open fracture protocol. Another thing that we noticed is that cefepime we only had for NS or LR, but if you do have D5W that you're using, it can be mixed with any of those and then dripped over 5 minutes. The antibiotic protocol criteria, you need at least two of these, which we were previously calling the latch criteria, but now we've changed to the CATH-L criteria, and it's all the same things. It's just that we found that not a lot of our agencies, maybe only two of them, are using a pre-hospital lab such as lactate. And so we decided to put that at the end. So now it's capnography, altered mental status, temperature, hypotension, but none of those changed. Also, as we referred to earlier, if the patient is on push-dose epi or levofed and they're still hypotensive despite fluids and pressors, now we have vasopressin as a second-line pressor option.
All right, moving on to the pediatric section. And again, a lot of these follow the adult changes that we made, and so I'll go through those pretty quick so you're not listening to the same items. But again, we removed the pediatric dosing chart because of the Broslo tape and hand tape usage by most of our agencies. On the allergic reaction, again, if you have that croupy kid that's stridorous, PO Decadron is just as effective as IV. And so what you can do is just draw your docetaxel out of your IV solution and have the kid drink it. You might have to mix it with some juice or something because it does not taste that great. But this is what we utilize in the hospital setting as well, as we just use oral Decadron and don't start an IV on these kids if we don't have to. The albuterol Atrovent, the IM epinephrine, and the nebulized epinephrine changed similarly as the adult section we talked about earlier. One change on the pediatric bradycardia, which we will cover in the slides again, is this is following PALS. And so we split the bradycardia treatment for a heart rate less than 60 by age, and that age definition is 10. So, and this, I know sounds kind of odd, but if you have a pediatric patient less than 10 with a heart rate less than 60, and they have an altered mental status, the recommendation is to start compressions and epinephrine on those kids. We consulted with specialists from pediatric hospitals here, ER doctors and intensivists, and this is what their practice is also. So if their age is greater than 10, then they get the same general treatment as we would an adult with fluids, atropine, push dose epi, and pacing. But less than 10, compressions and not pacing.
Yeah, and I think one of the, knee-jerk reactions that I had when I first heard about this recommendation was, you're telling me we're going to do this on a 9-year-old with a heart rate less than 60 who's altered and hypotensive? And the truth is that you wouldn't do it on a well-appearing pediatric patient that's 9 years old. You wouldn't be doing compressions. But if they were sick and they were bradycardic, and we thought that was the cause of their hypotension and altered mental status, actually you might justify that. And so this was a recommendation of our pediatric colleagues, and so we're trying to fall in line with that. But it does seem a little bit shocking at first. So we just want to point out that we were also shocked by that as medical directors. But this does seem to be the consensus of what we're asking folks to do pre-hospital. All right. So moving on to peds cardiac arrest, we added smoke inhalation just like adult. We had the 10-minute rule just like adult, the color Doppler just like adult, NGOG just like adult. We also have paralytic dose if there's clenched jaw. And then the magnesium previously was 25 to 50 mg per kg, and we just did a standardized dose of 50 mg per kg. Peds choking, just remember that if the patient is 1 to 14 years old, you're going to use back blows and abdominal thrusts. And if they're infants, they're really tiny, you can pick them up. Less than 1 years old, you do back blows and chest thrusts. Under pediatric ENT, the epistaxis pressure point is just below the nasal bone, so the very top of the bridge of the nose. Of course, the very bottom you don't want to be at. You want to be right in the middle, just below. If you cut the nose into thirds, the top third, middle third is where you want to go. All right, peds, nausea and vomiting, same as adult. Zofran was moved up to be the first line, and then the max of Reglan would be 10 milligrams, just like adult.
And on the peds open fracture, we added antibiotics again to the main set of protocols. The dose is cefepime 50 milligrams per kilogram with a max of 2 grams IV or IO for age greater than 2 months with suspected open fracture. Organophosphate poisoning and the psychiatric behavioral, again, the same changes as adults on wording and the dosing of atropine. On the peds respiratory distress, we added PO decadron where it's listed. We, again, like Dr. Maynard said, changed magnesium dosing to 50 mg per kg, and everything else, same as adult respiratory distress with regards to atropine epi and IM epi and nebulized epinephrine.
And for the respiratory distress, we specifically mentioned for croup to go ahead with the nebulized epi because I think those are the patients that are going to benefit the most from it.
Yeah. And a new item we added was this peds sepsis protocol. We did not have one previously. We worked closely with the RAC on developing theirs with pediatric specialists there. And you will see it is a busy document to follow, but within the RAC, we tried to get it reduced to as bare bones as we could, but just because of the different sizes and ages of pediatric patients, there had to be a lot in there. So you'll see it is very similar to what you would do with adult sepsis patients. And so we felt like it was important to add it since the RAC was going to it. And along with that, we also added a pediatric stroke protocol because, again, this was not something that we had previously. And we worked again with the RAC on this to come up with this. And again, it's kind of busy, but please take a look at it and become familiar with it. And again, we're always here for guidance if you need.
Yeah, pretty rare that a pediatric patient would have a stroke, but it has happened. I've seen one in my career. So they're out there. So we wanted to have a protocol for it. All right, moving on to the next section. We got trauma changes now. And so under general trauma, the push dose pressors, of course, were changed, which reflect the same indications for medical reasons. If you've been trained how to do an EFAST, you're allowed to do it. The TXA soak gauze for packing wounds. That's a kind of cool trick. If you don't have a hemostatic gauze already, you can make your own with using TXA. Um, Drowning, of course, was removed. We mentioned that several times. The trauma arrest protocol has a new look, but it's all the same content. And we talked about smoke inhalation, and then also we added a junctional tourniquet for various injuries that are below the umbilicus. Junctional tourniquet makes sense. Crush injuries, if we do suspect that they have hyperkalemia, of course, they may benefit from albuterol to shift that potassium inward. And the dosing is uniform along with respiratory distress and allergic reaction protocols. Also, pelvic binder and junctional tourniquets were added to crush injuries, of course, if they involve the pelvis.
On the head injury protocol, we changed the title from head spinal cord injury to just head injury. And we added systolic blood pressure goals of between 110 to 160. Previously, we just had it that we wanted them to be above 110, but we realized we didn't have a max. And so after consulting with our trauma and neurosurgery colleagues, we came up with 110 to 160, which is what the practice they utilize. And so you can achieve this with labetalol, IVIO, or cardine infusion if you carry cardine and are IV pump capable. On musculoskeletal, we added TXA soaked gauze and trauma gel for bleeding control. We added this because some of our agencies asked about carrying this new device called a trauma gel, which seems to work pretty good on those wounds that you can't get control of. But remember, it's not to be used in bleeding that's intrathoracic or intra-abdominal. Like Dr. Maynard said, we had a junctional tourniquet for hemodynamically unstable trauma patients with suspected injury below the umbilicus, age greater than 15. Okay, and so there's mainly two brands of the junctional tourniquets out there, the AAJT and the SAM. So whichever brand your agency is carrying, please take these out and work with them, because if you wait until trying to deploy it the first time you actually need it, it is kind of clunky the first time you work with these things. So it took me and most medics that I've worked with a couple of tries to really get proficient and efficient at placing those. And also, depending on which brand, has different indications if you are going to use one of these junctional tourniquets for a suspected subclavian or axillary injury. We had the antibiotic reference to the antibiotic protocols on musculoskeletal. On thoracic and abdominal pelvic, we again added a junctional tourniquet. And we also added, this is new for this year, a tourniquet removal skill. So we added this because we realized that sometimes pre-hospital partners that we work with, not us, but some, let's say, bystanders or police are pretty aggressive at placing on tourniquets, which we want them to be. But we also realize that some of them don't need a tourniquet. And if you show up to a level 1 or 2 trauma center with a tourniquet on, you're automatically activated as a level 1 trauma, which is significant cost for the patient. So if you feel like it looks like there was not really a whole lot of blood loss on the scene, or the laceration really doesn't look that deep that it would be the potential to have an arterial injury, we have that protocol in there for you to utilize to take off the tourniquet.
Yeah, so just follow the protocol. It's pretty self-explanatory. TXA, this protocol actually got a lot of revision. And so if you're an agency that carries pre-hospital blood, it will mirror that same protocol. It'll actually be a pre-hospital blood and TXA protocol. But for those agencies that are not carrying pre-hospital blood, it's just a TXA and hemorrhage protocol. And you'll see, we'll do a screenshot of that and kind of go through that. But just as a reminder, remember, we don't use it for GI bleeding for TXA, but you can still use it for hemorrhagic shock. And now the criteria are basically hypotension, a shock index greater than 1, or end-tidal CO2 that's less than 25. And we're giving it for the following indications for trauma, for either internal or external bleeding, or vaginal bleeding. And then, of course, we do not give TXA for GI bleeding because of worse outcomes and higher propensity to form clots. Also, the pediatric dose for TXA was increased to 2 grams max. You're still going to get a weight-based dose. All right, moving on to skills.
Okay, so on the CPAP and BiPAP skill area, and we'll show this in the slideshow again, we changed hard exclusion of inability to follow commands and hypotension to use with caution. And one of the reasons we did this is because if you have that COPD patient who is experiencing hypercarbia from their COPD exacerbation, this is sometimes the best treatment to actually get them more normalized and get them improve their mental status is to go ahead and utilize CPAP and BiPAP. Also, we added infant and pediatric indications for CPAP and BiPAP. They do make masks for these now, and so we have the starting pressures recommended there. EKG indications, we moved it to skills, and we also want to be sure that if you have more than one paramedic on scene, that at least two paramedics need to look and interpret every EKG to make sure we don't miss anything on these. IM and IN drug administration, we condensed it to one page with volume guidance retained, and we've covered the junctional tourniquet.
All right, moving on to Mediport. In the past, we used to say that, if you have a patient who has difficult IV access, they happen to have a Mediport, and we happen to access that Mediport, and then the patient later refuses, we would say, no, you've got to go to the hospital because you've got to get a heparin flush at the hospital. And the truth is that, this is probably an outdated way of practicing, and that most of the time in the hospital we're not flushing with a heparin after we've accessed the Mediport and we're disconnecting, and so we're just flushing with NS, and so it's no longer a hard stop. You can go ahead and treat a patient, flush their Mediport with saline, and they can still refuse. Granted, they meet all the regular criteria, alert and oriented, and have capacity to make medical decisions. All right, needle decompression. We'll show a screenshot of this in a minute. But basically, the anterior approach was removed, and now it's just the mid-axillary approach. And so if you have a pregnant patient, of course, that diaphragm starts to migrate upward as the uterus grows. And so you'd want to make sure that you would err to the side of going a little bit more superior or towards the axilla with those patients. And then also, if you happen to have a neonate that you needed to do needle decompression on, pretty rare situation, you're not going to use your big 14 gauge, but rather a 20 gauge needle instead. Pelvic binding, just a reminder that you do get better hemostasis of a pelvic bleed if you internally rotate the feet together. And so just a reminder there. And then also, of course, you want to put it over the greater trochanters, kind of like low-rise jeans, kind of just sitting over the hips, but not all the way up around the pelvis. RSI, okay, so quite a few changes here. So the ketamine induction dose got increased. We had a number of complaints from paramedics that were giving the 1 milligram per kilogram and saying, I don't think this is enough to get the patient to adequate sedation. And so we increased it to 1.5 now on a max of 150 milligrams total, or if you're pediatric, 75 total. And so we've increased that. Now, let's say that you give that 1.5 mg per kg and you're getting ready to intubate, but you still don't have an adequately sedated patient. Let's say, and it's an adult patient, you give it 150, you can give an additional 0.5 mg per kg. So that would be another, 50 milligrams total for a total of 200 milligrams in order to get the patient sedated. So just to clarify, this is not a post intubation sedation dose. This is an additional dose needed to get the patient sedated in the first place for your RSI. All right, moving on to paralytics. We actually reduced the dose of paralytics. And so it used to be 1.5 to 2 mg per kg, and now it's just 1.5. And we feel like that's an adequate dose. If you're using VEC, which I don't think a lot of agencies are, now the dose is simple. It's just 0.1 mg per kg. We talked about push dose pressors updated to increase the dosage, and the only exception to the rule of the resuscitate before you intubate, if you have a rapidly closing airway, this is the time where you may not get over that 94% pulse ox, because that patient has a window of opportunity that you're going to miss. These are your angioedema, your your severe anaphylactic allergic reaction, where they are going to have lose their airway if you don't act now. And so we're not going to worry about the resuscitate before you intubate rule as much, but this is really the only exception to that. The dosing chart for RSI was removed. Not a lot of people were using it.
On the RSA, we kind of talked about it earlier, but it's now its standalone skill set. And so we talked about the indications for that earlier. On the intubation ventilator section, we changed from percutaneous transtracheal ventilation to needle cricothyrotomy is preferred language now. And we removed the wording and age restriction from the ventilator section for pediatrics. Transcutaneous pacing, we just added that you can repeat sedation. We realized that we did not have a repeat dose available when you looked at especially if you were following the flow chart for bradycardia. Medication changes, we clarified 3 calcium gluconate equal 1 calcium chloride. And again, this is to get your elemental calcium dosing equilibrated between those. And we also recommend that you dilute calcium chloride if you use it outside of cardiac arrest because of the extravasation risk with calcium chloride that can be pretty severe. Again, cefepime was added as a standalone drug now. We expanded contraindications for diltiazem to include bradycardia and heart block. And on the epinephrine 1 to 10,000 push dose, we expanded it to hypotension and the preferred agent if bradycardia is present.
All right, and then moving on to magnesium sulfate, we added an IM route in case you could not get access, and for pediatric VF or Torsades and also respiratory was all standardized to be the 50 mg per kg, so that way you only have to remember one dosage. And of course, we talked about this earlier, but the OB dose for eclampsia was reduced from 6 to 4 grams. Metoprolol is a new medication that some agencies are choosing to use in place of diltiazem. And so it would be used for, your atrial flutter, atrial fibrillation, or any narrow complex tachycardia in place of diltiazem. Nitroglycerin, there's different ways to mix a nitroglycerin drip if you happen to be using IV nitro. Norepi, we talked about how we increase the push dose volume, and then also indications for if you had post-ROSC. Vasopressin, we already talked about as a second-line agent for hypotension. So that's the end of this document. And now we're going to move on to the second part here. And
Dr. Maynard, I'll say one thing that just came up to me this week that we'll need to change for next time is on the medications, is that if you're utilizing Narcan in a pediatric case, we currently don't have a max dose. We just have the pediatric dosing. So again, just utilize the 2 milligrams, the same that you would for an adult on the max dosing.
yeah, really good call out. So, all right. So now we're going to go through the slide deck. This will be great for those of you that are a little bit more visual and want to see the side-by-side comparison. And so away we go. So just a little bit about how to interpret this slide deck. Basically, if it's green, it was added in 2026. If it's yellow, it was modified. And if it's red highlight, it was removed. So this is basically just a big overview, and feel free to take a look at this. This is all the stuff we've already covered, but just kind of by section. And everything's kind of color coded there for you, which matches the colors of the PDF document that we have been going through. All right, so we'll start in the high-level organization changes. So the patient assessment section previously looked like this in 2024, and now, of course, it's removed, so it's gone. This is our new tachycardia protocol. So the flow chart used to look like the one on the left, and now it looks a little bit fancier and easier to read, a little bit more streamlined. And you can also see that metoprolol is ordered for the narrow complex, not this one, but for the narrow complex. Traumatic arrest, you can see a little bit easier to read in terms of the clarity, but it's all the same content, and that has not changed. All right, moving on to the general information section. The state
So
clarification was added. Oh, Skipper, do you want to talk about this?
yeah, I can take this section if you want. So this is the state clarification that was added regarding definitions where we had to define scope of practice or if capable and consider. So again, just reference these if you need to. On the next page is the scope of practice changes highlighted in green here. So again, on EMT level, you can assist patient with their own intranasal epinephrine. We added PO or ODT Zofran, and then also ophthalmic drop administration. And on the AMT, cardiac arrest only for intratracheal intubation and lidocaine for IO access, and also added IV and IO fluids. And again, in the paramedic, we removed the section, the skill of chemical restraint.
Good deal. All right. And then for allergic reaction, mild and moderate, remember previously albuterol was only 2.5. So now you can see the side by side here. We increased both the albuterol and the Atrovent. So basically, instead of just one duo neb, now you can give up to three in the nebulizer canister all at once. And you can see under the severe protocol, quite a few changes here. We've already talked about these, but now we're just going to look at them side by side. So the epi-IM, or kind of the quote unquote EpiPen dose, has been increased from zero point 0.3 now to 0.5 milligrams IM. The anaphylaxis criteria, remember you need two or more of the following, and that would qualify as anaphylaxis. So you can see, as Dr. Bertrand was referring to earlier, you have multiple body systems involved here. Also, if you're treating any type of wheezing, the albuterol dose and Atrovent is increased, as we've mentioned several times now. And then, of course, the nebulized epi. So now you can kind of see them side by side and see what's there.
Again, the next section is our adult cardiac arrest, and Dr. Maynard talked about this, but remember, we want to give these patients the best chance of survival, and we feel that that's going to be performed in with more personnel available if you're on the way to the hospital when the cardiac arrest occurs. So as soon as you're to a safe area, we should pull over and begin our resuscitative efforts at that time on the side of the road. The next page shows the new dosing for the epi and leading-fed push dose pressors from just 1 milliliter to 1 to 2 milliliters as an option. And then the next page will show you the hyperthermia protocol. So we added the cooling target. And at the end of this, we will try and bring up the new protocol for cold water immersion that we can go over with you. We can bring that up later, Mark.
Okay. All right, moving on to the pediatric section. So this is the bradycardia section we were referring to earlier. So you can see altered mental status got added as another sign. Of course, hypotension is your main way to tell if this patient is symptomatic or not. And so we're still going to use hypotension, but also altered mental status. And then, of course, we talked about the breakdown. So less than 10 or greater than 10 age. And so if less than 10, CPR and epi. And then greater than 10, we can do all of these things below. So atropine, push dose epi, and of course, pacing. And so that's how it looks in the actual protocol compared to the way it looked before. For pediatric, we now have an open fracture protocol, so there's no comparison because this is a new one. And you can see the dosage of cefepime is there. For the respiratory distress, severe pediatric, this is the old versus the new. So you can see this kind of mirrors the adult protocol with the weight base. So again, you're for epinephrine IM, typically, like an EpiPen would be 0.3 for pediatric, but you could go up to a max of 0.5 depending on weight. The weight-based dose, of course, is 0.01 mg per kg. We can see here that we added PO. It'd be easy to miss this if you weren't looking closely, but Decadron specifically, like Dr. Bertrand was mentioning, is a great alternative, especially for your croup patient. You don't really think they need IV access, but you do think they need steroids to help with the croup, and so giving a PO dose is a great way to avoid an unnecessary IV. And you can see the other changes such as albuterol and magnesium are the same way that we referred to earlier. All right. And Skipper, do you want
And
to take this
this,
next one?
yeah, so this is the new sepsis protocol that we added for pediatrics. So you can see the first section is a criteria. And so if you answer yes to all three of these questions, then activate it as a pediatric sepsis alert. And there's a criteria you see listed on there. We have specific parameters for age groups for their heart rate and respiratory rates, and also signs of hyperperfusion in those age groups and what you would look for signs of neurological dysfunction. So again, it's somewhat busy with having this reference here, but we wanted to give you an option for those pediatric patients that meet sepsis criteria. And again, much like adults, we want to try and have dual IV access on these patients, give them the full sepsis bolus of 30 milliliters per kilogram, and hopefully hit your that during transport, and then our sepsis alert notification and the minimum fluid rate note.
Very
On the
good.
next, what's that?
Go ahead.
Okay, on the stroke protocol. So this is our previous stroke protocol you see here on the left, where we just had basically, checking glucose, common things we do. We do have the new stroke pathway. We just don't have it up here yet, but it's much more definitive and gives you much better parameters. It's who to transport where.
Yeah, and you'll have to refer to your protocol for that. Unfortunately, I don't have a screenshot of that specific one.
Okay.
So moving on to trauma section. So head and spinal cord now just is referred to head. It's really kind of difficult to diagnose spinal cord injury in the field. Um, and so also, as we mentioned before, now we have a systolic goal of 110 to 160. And the reason why is because if it's an isolated head injury, we probably want our blood pressure to be low, but higher than if they had a chest or abdominal injury. And so one of the problems with creating this is if it's isolated head, you probably could keep your blood pressure around 140. But if you had multi-system trauma, including a head injury, now the trauma surgeon is going to tell you to keep your blood pressure goal around 110. So what we did is we kind of just created a range. And so you want to try to stay within this range if you can, not above, not below. But also, if you have a patient that has trunk or abdominal injury and their blood pressure is a little bit low, I would use caution before giving them any type of antihypertensive because I think you could get yourself into trouble if they had internal bleeding. They're going to become hypotensive, especially if you give a medication that drops the blood pressure, such as labetalol or cardine.
And this is
And
our
this
new
is, go ahead,
removal
Skipper. You can go.
tourniquet removal protocol process. So you can look at it. We have some bullet points on to when to consider it, and basically some contraindications. So if they are hypotensive, are they getting worse? If the tourniquet time is unknown or greater than 2 hours, if there is a traumatic amputation, and if the bleeding looked like it was severe, if there's a whole lot of blood around their extremity where they are laying, or it's still in control, then don't take the tourniquet off at that point. Okay. We have some pretty specific instructions on how you can go about removing it. And remember, this is a one temp only kind of deal. So if you loosen it and it looks like there's a pretty good amount of blood that's starting to come out again, then we would retighten it and leave it in place as is and transport at that time, as long as you have them adequately resuscitated, hopefully.
Yeah, and another kind of teaching pearl here is that if you loosen the tourniquet, you don't need to remove it from the patient. It's not tight, it's just sitting loose there because if for some reason that patient disrupts the clot, they start to bleed again, you would want that tourniquet in place right where it was working before. So definitely do not take them off. And then also it allows us to communicate with the ER that, hey, there was a tourniquet in place and we've loosened it and using our tourniquet removal protocol. So maybe we should have named it the tourniquet loosening protocol instead, because we're really not removing it completely. But maybe next year or in the next 2 years, we'll change that.
Yeah, good point.
All right, so this were the TXA protocol that we were referring to earlier. So this is for hemorrhage. And remember, it looks very, very different than previous. So let's just kind of go through side by side. And so you can see we're basically giving TXA for anybody who's in hemorrhagic shock. And for what reason? Well, we talked about trauma. It could be blunt or penetrating, internal or external bleeding, OBGYN bleeding or GI bleeding. But of course, we do not give it for GI bleeding. So it's literally stated there as reference because they have worse outcomes. We don't give TXA for that. But this is exactly the same protocol indications as for pre-hospital blood. So if you have an adult versus pediatric, if you have one physiologic sign, so any of these four, and if you take out traumatic arrest, it basically is just three. So as we mentioned earlier, hypotension less than 90, shock index greater than 1, and also end-tidal CO2 that is low, less than 25. And then we do, of course, for pediatrics, an age adjustment, but shock index and the end-tidal CO2 remains the same. Now, of course, if you have a patient who's in traumatic arrest and they're in asystole when you find them, their chance of survival is incredibly low. And so these patients we're not going to give TXA or blood to because we really don't resuscitate these patients at all, just because of what the literature shows about their chance of survival is, a fraction of a fraction of a percent. And also, if you need to remind yourself on what a shock index is, it's listed there for you. It's just heart rate over systolic. All right. And so also the pediatric max dose for TXA was increased to 2 grams, which is, of course, the same as the adult. All
And
right,
moving on
moving
to the
on to
skills
skills.
section. So again, several standalone skills were removed just to reduce the bulk of the protocols. On the CPAP BiPAP, again, we made was previously an exclusion criteria of an inability to follow commands into a use with caution so that you still have that option to treat them. The needle decompression, again, the anterior site was completely taken out. High failure rate when you look at those on postmortem cases. And also, we then placed just the lateral access as the site for needle decompression. On the transcutaneous pacing, again, we had to consider sedation, but we didn't have a repeat dose available. And obviously, these people often will need repeat doses of sedation. So that is there for utilize also now. And again, on the skills, we also added the RSA skill that you can review.
All right, and moving on to medications. Remember, we added those 3 new medications. Of course, you are not required to carry these medications, but they are an option for those agencies that decide to carry them. So we thought we'd make a nice single chart where you can see all the medication dose changes in one format. So here you go. You can see all the changes that were made indicated by an arrow from 2024 to the new 2026 protocols. And so feel free to print this out or reference it, and we'll send this slide deck out to everybody as well. All right, so just a quick wrap up here. Basically, these are the things that we added here. These are the things that we removed or relocated. We have the things that we removed or condensed, and then also some language change here. So if you have any questions about this presentation or the new protocols, please reach out to your EMS leadership or your medical director. And we want to thank you for your time and attention.
And Mark, if it's not too much trouble, I did email you to your IES email, the cold water immersion. Okay. So this is our new cold water immersion protocol that we apologize. We just came out with this right after we had already submitted all of the previous new protocols. So it is currently a supplemental protocol, but there's a lot of research that has recently come out that shows, again, everything is pointing more and more towards us treating these people and resuscitating them on the scene, improves their outcome from a multitude of diseases. And this is one of the biggest ones that we can improve their outcome. So this is going to be applicable to those patients that you suspect of having a heat stroke. So not just heat exhaustion, but we need to be meeting the criteria for heat stroke with altered mental status changes, okay? And so a couple of new changes, we're going to need rectal thermometers. There's a huge discrepancy between a core rectal temp and what you get with oral temps and or axillary or tympanic membrane temps. It can be as much as 2 to 3 degrees difference. So that really determines our treatment, right? If we are looking at 2 to 3 degrees difference. So we want to get these people, if you're at an athletic facility, hopefully they should have a cold water immersion tank you can get them into. Okay, your monitoring options are going to be limited. You can't have the monitor hooked up to them while you're doing this. You can have the ear probe pulse ox on their earlobe, um, hopefully, but your warranty will be voided if something happens to your monitor while the electrodes are submerged in water. Okay, so unfortunately, monitoring is limited, but we want to start treatment if, again, they're over 104, they have mental status changes, and with this, you should be able to reduce their core temperature by zero point 0.3 to zero point 0.4 degrees per minute. So it's going to require rectal temps every 5 minutes. Okay, so it's a little bit cumbersome, but again, this is giving our patients the best chance of survival. Okay, we want to take these patients out of this once we hit the temperature of 102. So again, like Dr. Maynard talked about earlier, we don't want to overshoot that core goal temperature and then get them shivering and starting to generate heat again. Okay, um, and if you don't have rectal temps available, then cool for a minimum of 15 minutes or until their mental status hopefully improves. Okay.
Yeah, and Dr.
Don't,
Bertrand, I'll just point out that if you did cool about zero point 0.4 uh, um, degrees every minute, and you're checking every 5 minutes, you might expect about a 2-degree reduction and during that time period. So, for example, if you started out at 106, in 5 minutes, you might get all the way down 2 degrees down to 104 the next time you check it. So, just kind of give you an idea of a real life situation.
yep. And as troublesome as it sounds, please, if they start to develop uh, vomiting or diarrhea, combativeness, or seizures, we want to try to keep them in the tub and keep them cooled. Um, and then once our core temperature is met, transport them to the hospital. But again, we don't have a good way of doing this in the hospital, so it's really going to be on us in the field to get this done for these patients. And if you have someone with exertional heat stroke, we can reduce their mortality from that to near zero by getting them cooled rapidly in the field. So how are we going to do this? So again, if you're at an athletic facility, they should have a cooling tub available, hopefully. That's going to be optimum. But if not, then we're going to need to send a crew member, a supervisor, or someone to get some ice. If you're at a home, I would utilize their bathtub. Start filling up their bathtub with cold water, get ice or frozen peas or whatever they have in their freezer, and start dumping it into the bathtub with them until someone can get some ice. There are some commercial products available out there. They are rather expensive. And so I think the best thing that we could utilize would be body bags. If you carry body bags, it's not the best look optically, and we don't like it. But it's unfortunately we're focused on not optics necessarily, but giving our patients the best chance of survival with this, right? So you can just utilize a body bag, fill it with cold water, put some ice in it. Again, keep patients obviously their head above the zippered part of the body bag. And you can use water from a hydrant, from garden hose. Don't use water that's in an apparatus because that has probably been sitting out in the sun or could possibly have been sitting out in the sun and getting to high temperature elevation as well. And again, just ensure you know your ABCs, and hopefully you'll see some really good results with this.
All right, very good. So that'll conclude this protocol revision video. Hope this has been helpful. And again, if you have questions, please reach out to us. And thank you for what you do.
Yep, thank you.